Hi, my name's Sue Everett. I'm a senior nurse practitioner at King's College Foundation Hospital in London in the UK. I work in a sexual health department providing contraception, sexually transmitted infection treatment and diagnosis, and I've worked here for a number of years. I'm going to talk to you today about contraception. I'm not going to talk to you about anybody under the age of 16 because those have child protection and Fraser guidelines in this country that we adhere to. I'm also going to be using the information from the United Kingdom medical eligibility criteria, which is called the UK MEC criteria, which is based on the World Health Organization criteria for contraception, which came out in 2009, and you can look at that, and that's really helpful. All the information as well that we go back to and look at is from the Clinical Effectiveness Unit at the Faculty of Reproductive Sexual Healthcare, and that's available to you. It's based in London in the UK, but is easily accessible on the internet and is a very helpful resource in contraception. The patient I'm going to talk about today is a young woman who attends the clinic requesting more combined pills. She has been on the combined pill for 10 years, accessing it from other clinics, GPs, other doctors. The person I have in mind, and this is completely confidential, it's not based on any particular person, attends, and during the consultation you're trying to find out whether they're suitable to go on the combined pill. The reason we do this is because the combined pill has a higher risk of a venous thromboembolism, and there are two groups of combined pills. We work with second and third generation pills. In the pill scale in 1995, we found that third generation newer pills had a 25 in 100,000 risk of a thrombosis. We tend to put people on second generation pills in this country, and they've got a lower risk of a thrombosis of 15 in 100,000. So we're assessing to see if this woman has a thrombosis risk, so we want her weight to be normal, under a body mass index of 30, for her to not have any risk of venous thromboembolism in her family, under the age of 45, to be have not had a thrombosis herself, and also not to have any liver disorders, any medical history of relevance to like cancers, any epilepsy, and not to have something called a focal migraine. The patient I have in mind had been on, as I said, the pill for 10 years and had been getting focal migraines, and she described them by she'd started to lose her vision, and she started to lose her vision halfway over her eye, and as soon as she sort of brought her hand up to her face, I sort of began to think, yeah, this is probably a focal migraine. And she said, yes, and I sometimes lose the ability to use my left arm, and sometimes I lose my speech. So she had a much higher risk of having a stroke being on the combined pill. But actually persuading her to come off the combined pill was actually quite difficult, because she said, well, I've been on it for 10 years, so I've been all right. That's my risk. I know about it. You're telling me there's a risk. You give me the pill. That's my risk. And I said, no, actually, in this situation, it's not your risk. It's about making sure you're safe, but also we're not willing to take the risk of putting you on something that increases your risk of having a stroke. So in this instance, eventually I persuaded her to go on a progesterone-only pill, and we would put her on, in this country, a pill called Cerazette, which is made of desogestrel and is the only progesterone-only pill that inhibits ovulation. The way to persuade people, I found over the years, is when people have been on something and they think that they don't understand the risk, is to perhaps also talk to them about strokes. And what I talked to her about and said, look, if you have a stroke, you're getting these symptoms, you're losing your left arm sometimes, you're having a problem with your speech, is, do you know what a stroke is? And a lot of people actually don't understand what a stroke is, and the fact that she might permanently lose that part, or the ability to use her left arm, or the ability to speak properly, or to be able to walk properly. people do tend to think it won't happen to them, but she did eventually go on the progesterone-only pill. She could have gone on to any other progesterone-only methods, or she could have had an IUD or an intrauterine system. So there were other choices, but not combined methods like the pill, the patch, or NuvaRing, which all contain estrogen, which increase this risk of a stroke with focal migraines. And the other important thing at the end of this consultation was for her to understand why she couldn't have these methods, so that she really understood, and that so she didn't go off to somewhere else and perhaps not tell people about this migraine and put herself at risk, that she understood that we were, and by the end of it, it took a long time. So these consultations do take longer than perhaps as sort of somebody with no health problems, but she did change, and she did understand at the end. The next patient I'm going to talk to you about is somebody accessing the service wanting a pill called Dianet. If you're in other countries, you may know it under the name of cytoproterone. It sometimes comes under names like Diane. But it's a pill that is not actually a combined pill. It's a treatment for acne, and patients are often on it for acne treatment, and the byproduct is that it works the same as a combined pill. In this country, in the UK, we only prescribe this pill for 6 months because it has a higher risk of a venous thromboembolism, I talked to you about earlier, but also it has a higher risk of liver problems. So you should only be on it for 6 months, and in fact, generally the advice is that people actually have, for treatment of acne, they have sort of low dose antibiotic treatment rather than this. But we get people coming on it and they have had it as a repeat prescription. They've had it for longer than 6 months, and we usually come, and they've had it for acne treatment, but they want a pill as well for contraception. So what we tend to do is they'll come in, we'll talk to them about it, and we'll explain the risks. We never have these pills in contraceptive clinics, so we don't have it to give them anyway. So we usually change them to a third generation combined pill that has a slightly higher risk of a thrombosis. It has a 25 in 100,000 risk of thrombosis, but pills that contain desogestrel and gestodine as their progestogen with the estrogen tend to be better for your skin. And probably the pill I would put her on in this country would be Marvelon or Gederal 30. It's exactly the same, just two different drug names, and that is excellent for really improving your skin. But it's got a lower risk of thrombosis than the Dianet had in the first place. And it's about talking to people and explaining that the risks are lower and this would be better for them. So I've spoken to you about some scenarios earlier. What I'm just now going to talk to you about is some of the other things that we take into consideration when we're doing a consultation about contraception. So when a woman comes in and she's requesting contraception, I always want to know what she has thought about and what she wants to use, but also what she's used in the past and why she used them, and did she have any problems with them, and how long she used them for. Often people stop using something, and especially with pills and young girls quite early on, they might have used pills for only a couple of months, and any side effects they would have had haven't gone yet. They might take a bit longer. So sometimes people have given up too soon really with a method. And you can address these things and you can educate people, you can talk about the side effects, and that may make them reconsider having that method. The other thing I want to know is how important it is they don't get pregnant, and what would they do if they got pregnant. So for instance, if they got pregnant, would they continue? Would it be a slightly early pregnancy that they would be happy with, or would it be devastating and they would consider an abortion? If it's in the latter, then I would be looking for methods that are more contraceptively effective so that they don't get in that situation in the first place. And then I'm looking at, what are their periods like? Are they heavy? Are they painful? If they're heavy and painful, and we have patients that might have periods for 2 weeks each month, and they can be very heavy and debilitating, that will cause anemia, it costs a lot of money to provide sanitary wear, and it will be ruling their life. So choosing a method of contraception that will actually provide contraception but might make their periods less painful, less heavy, is going to be a bonus to them. So and those could be combined methods, progesterone-only methods, the injection, the intrauterine system. And they're particularly good for causing amenorrhea for the progesterone methods. The implant is not as good for helping heavy painful periods because you still get a lot of irregular bleeding with it. But Depo-Provera, Cerazette, progesterone-only pill, and the intrauterine system are really, really good for effective control of heavy painful periods and are more likely to cause amenorrhea. And as long as you warn the patient about that can be a real gift for them. If they've suffered from heavy painful periods, then you might want to scan them if you're having an intrauterine system, because you want to make sure that they can fit an intrauterine system in the cavity of the uterus successfully. And maybe they've got fibroids, and fibroids wouldn't stop them having it, but it just depends where the fibroid was. So you want to organise a scan so that can be done at the same time or done before the insertion of the intrauterine system. And a lot of contraceptive clinics in the UK now have portable units that they can do that on site. If somebody's got fibroids that do distort the cavity, then the injection at Depo-Provera that we use, which is a 12-week injection, widely available across the world, is a brilliant source for causing amenorrhea and is very, very good for heavy painful periods. So these things you're going to think about in your consultation. You're also going to think about how easy it is for somebody to take that method, how successfully they've taken them in the past. Are they good at taking pills? And often with pills, it's a good way of reminding them, what would you do, how do you take it, what would you do if you miss pills? So setting phones to reminder, and everybody in my experience these days seems to have a mobile phone. So a mobile phone reminder is good. If they don't have a mobile, it's getting a watch with an alarm on it, carrying the packet with you. Most women do not go out somewhere without taking some sort of form of bag or purse or something with them, keeping that with them. So they've always got it. So if they are taking it, they've got it there to take with them. Giving them those little clues always helps. Telling them to take it at a time when they eat, they clean their teeth, something they regularly do, so that they've got a permanent reminder to take that method is always a good thing. If you've got patients that regularly take other drugs, that might be a diabetic, then often taking the pill at the same time as those is good, because they won't forget those either. So, taking them in one block can be okay. Finding out what other drugs, medicines they take, because they might interact, and always checking there's no interactions with the contraception that make it less effective, but also there's no interaction on the contraception on another method. So for instance, you might have somebody that's taking HIV drugs, things like that. You want to make sure that there's no interaction between them two. And also, patients aren't always very good at telling you about things that they take over the counter. So often people take herbal remedies, and there isn't as much research about the effect of herbal remedies. They can be very good, but they can stop other methods of contraception working. So thank you for joining me this afternoon. I'm sorry about the noise behind me. You can hear lots of police sirens, but we're a busy London hospital, so that's where you get all the noise behind you. It's been really great to talk to you about contraception. There are some references on the website that will give you further information, and good luck with your clinic. Bye bye.